in each case in a little bit more detail so that you can understand the difficulties behind and the solutions. And we will have a Q&A after the presentation. There are two kinds of all-on-4. One, we call it the all-on-4 standard, and the other one we call the all-on-4 hybrid. The all-on-4 standard, that means that all the implants are placed in the mandibular bone or maxillar bone. The all-on-4 hybrid means that the implants are placed in the maxilla, but also outside the maxilla. And outside the maxilla can be in different places. It can be in the zygoma, which is the most normal place. It can be in the pterygoid. Can be in the orbit room as well. It's hybrid because, as you know, a hybrid is a mixture of two different things. And we call all-on-4 hybrid because we are using maxilla bone and outside the maxilla bone for the anchorage of the implants. There is a third kind of all-on-4. We call it all-on-4 double zygoma. In fact, this means that it's not an all-on-4 standard, it is not a hybrid, it is an all-on-4 made with implants outside the maxilla. And this means it normally means that we have two implants in the zygoma in one side and two implants in the zygoma on the other side. Can also be one implant in the zygoma and another in the pterygoid. Can also be one implant in the zygoma and other in the orbital room. But it can also mean only two zygomas, one in each side, for a 12-teeth rehabilitation. That is a special rehabilitation that we will not talk about today. This is something that is still under construction, and the first results will be at the end of this year. So that type of all-on-4, in fact, it is not an all-on-4, it is an all-on-2. That type of rehabilitation we will present during next year. But I just want you to understand already that when we work with zygomas, we actually do not need 4. We have a lot of cases of only 3. So this is important. And yesterday I mentioned that we started the all-on-4, the project of rehabilitation of the maxilla. We started with 2 implants, 3, 4, 5, and 6. And we studied all these combinations, all these possibilities. And the best of all of these possibilities was the 4 implants. And therefore we call it all teeth on only 4 implants, which we shorten and becomes all-on-4. So that's how it started. But I also mentioned yesterday that 3 implants also work, especially in the mandible. So it is important that you have your mind open and that you understand that nothing is just one way. We have to have our minds open. We have to look at the cases. Obviously, we have to have a guide, and our guide is the all-on-4. But if something happens and you do not have enough bone, normally because of cancer, sometimes because of trauma, we only place 3 implants. And sometimes we place 5 implants. And sometimes we place 6 implants. For instance, when we have very soft bone or very little bone in the maxilla, we are placing 2 zygomas, 1 in each side, and we are placing 4 small 7mm implants in the front, and that is 6. So, although we have a protocol called all-on-4, we have to adapt. We have to adapt to each case. We cannot just think about all-on-4 and place 4 implants all the time to everybody. That is not intelligent. So we go through today again through a all-on-4 surgery. Important to understand, there is an incision in the crest slightly palatal. There are 2 incisions in around the molar area, which we call release incisions. Then we do a full thickness flap. A full thickness flap means that the periosteum comes with a flap. This is very important for healing and for stop bleeding. And then we trim the bone if necessary, and we place the pin guide in the middle. That pin guide helps us to place the 2 implants parallel to each other. We place the 2 implants in the front. Normally, these implants are bicortical. Bicortical means that the implant apex actually crosses the nasal floor. And then we mark the anterior wall of the sinus with a pencil, making a window. And we perforate in such a way that we do not fall into the sinus. So we perforate about 3 to 4 millimeters forward of the pencil mark. This osteotomy normally is 45 degrees in angulation. Then we use a bone mill to remove the bone around the head of the implant. This bone mill has been designed in order to remove the bone on the head of the implant without damaging the implant, in order for us to place the 30-degree abutment. In the all-on-4, we can use 30-degree abutments, and also we can use 45-degree abutments, as well as 17 degrees abutment. Once you place another anterior implant, normally in the front we use 2 millimeter multi-unit. Then we do exactly the same on the opposite side. We drill with a 2 millimeter drill all the way, and then the 3-2-3-8 drill only part of the way. If the bone is dense, we drill all the way. If the bone is not dense, we only use the 3 to 3/8 drill for the first 3 or 4 millimeters. And then we do exactly the same. We place the angulated abutment and we suture everything back, removing excess soft tissue if necessary. We do not want too much soft tissue. Then we use a punch, and with the punch we make sure that the abutments are all visible. Then we connect the impression copings. And after connecting the impression copings to the implants, we connect all the impression copings with a wire and with a low shrinkage acrylic. Once that is done, we use putty soft to push against the impression copings, and we place also putty soft in the tray, and we make a pickup of the impression copings. This is the surgical protocol of an 014 standard, and this is the protocol of impressions in an 014. As you have seen, this surgery, the surgery itself, takes about 25 to 30 minutes. After that, we take the prefabricated bridge, we place the 2 cylinders in the front, and we pick up the 2 cylinders with the prefabricated bridge. As you can see, first, of course, we try in the prefabricated bridge, we check vertical dimension, and we check that the bridge is as the midline perfectly correct, and also the horizontal plane, as well as the lip support. Then we take a bite registration with silicone, occlusal silicone, and then we remove the bridge, and the bridge comes with the cylinders, as you can see. We give to the lab. The lab places the other 2 cylinders because of the model that was developed. It fills up with more acrylic. It cuts excess acrylic, polishes, and within about 2 hours, from 1 to 2 hours, we place the bridge on the patient. After placing the bridge, we check occlusion. We do not want any prematurity, and also we want canine guidance and incisal guidance on protrusion. We polish the bridge, we check occlusion, it's canine guidance on one side and on the other side as well. And the case is finished. So now we tell the patient to go home. We remove the suture about 10 days after, and the patient goes with a 10-day medical protocol, which is 10 days antibiotics. The first 4 days we give cortisone, dexamethasone, and the next 6 days we do ibuprofen. The patient is instructed to to have ice for the first 2 days and to eat anything he wants besides biting on hard food, like avoid apples and bones and nuts, but the patient can eat anything else. He can eat hamburgers, fish, pasta, bread, everything. Just avoid bones, nuts, and hard food. So, let's go through each case and the difficulties of each case and the solutions of each case. Case number 1. We have a patient with periodontal disease on the lower, on the mandibular, and the loss of teeth on the upper, with an irregular residual crest. You can see that the crest is not regular. There is also a root on the right side. So when we look at this situation, we know that first we need to remove the root, obviously, and we need to trim the bone. We should not do the surgery. We should not place the implants with the bone going up and down. We should trim it so that the bone stays more or less flat. It's very important that the implants are more or less the same plane, not one up and one down. The third thing that we should look in these cases is the gummy smile. So before the surgery and before the anesthesia, we remove the denture of the patient and we ask the patient to smile. And when the patient smiles, we look and we try to see if the patient has a gummy smile. If the patient, without the prosthesis, without the denture, if the patient does not have a gummy smile, we are good. It's an easy case. If the patient has a smile, a gummy smile, then it's a difficult case. And a difficult case depends on how much bone we need to remove. Remember that the more bone we remove, not only the less bone is left, but also we are removing the best bone, which is the bone of the cortical. So we should only remove bone if it's strictly necessary, because we do not want to remove bone. But if you have a gummy smile, we have no option. We need to remove bone in order to give a nice smile to the patient. So, 2 things that are important to understand. Number 1, we only remove bone if necessary. Removing bone, it's not good. Second, we only remove the bone, the minimum bone necessary to avoid a gummy smile. So these are 2 important factors. And this is the intraoral picture, photo, and you can see also that the soft tissue has inflammation. This is typical from patients with dentures. So normally this type of inflammation is not serious. It goes away after 1 week that you remove the dentures. But sometimes this inflammation causes the soft tissue to be very soft and to tear very easily when we open. So when we see this type of inflammation, we need to be more careful in opening the case. Also, sometimes we see that the soft tissue is very thick, and we do not want very thick soft tissue on top of the abutments. We should not have more than 3 millimeters. So if the soft tissue is 5 or 6 millimeters or 7 millimeters thick, we should trim it. So the way we trim it is we open the flap and we slice the flap from underneath. So we divide the flap in half, remove 2 or 3 millimeters from the underneath the flap, from the part of the flap that is in contact with the bone. So after 10 days, it should look like this. After removing of the suture, so after 10 days, the patient comes, we remove the breech, remove the suture, wash everything, put the breech back, and check occlusion again. This is very important, and most people are afraid of removing the breech after 10 days because they are afraid that they'll damage the implants. And that is a mistake. You must remove the breech after 10 days. You must remove the breech. There is nothing wrong. There is no danger in removing the breech. Removing the breech is essential to remove the suture, to wash everything. Because during the first 10 days, patients do not clean very well. They are afraid. So you need to remove. Do not be afraid of removing the breech. Screwing the breech back cannot damage the implant because the prosthetic screw is screwed at 10 newtons. 10 newtons. And if a prosthetic screw at 10 newtons can turn an implant, then that implant should be taken out immediately. Another thing that is very important is you must look at the emergence of the screws. And this, for instance, you can see here that you have 2 implants in the front and the screws come in between the central and the lateral in the pink part of the breech. That is perfect. On the back, you can see that the screws are coming in between the 2 premolars. That is wrong. The screws in the back should come in the pink part of the breech, should not be on the occlusal part of the breech. Because if the screws are left like this, it is very difficult to reconstruct the tooth. And if the tooth is a ceramic tooth, it's impossible to reconstruct with ceramic. because the hole of the access to the screw is in the corner of the tooth. If it was in the middle of the tooth, maybe it would be okay. But if it is on the corner, of course the tooth breaks. As you can see, it's not possible to keep the tooth in one piece with the hole on the side. Especially the one on the left side from you. The one on the right side, it's not too bad. But the one on the left, it's not possible. So, what must we do? During the surgery, we use the Malo guide. But even with the Malo guide, it is very difficult for us to guarantee that the screws are coming exactly where they should be. Which basically, every screw should come on the pink part of the bridge. And this is another mistake that people are saying. People try to make the screws come out on the occlusal surface. Screws must not come out on the occlusal surface. They must come on the pink part of the bridge. So, the first bridge, the temporary bridge, the bridge that is placed on the day of the surgery, serves to check all these points. For instance, in this case, we know that we must rotate the angulated abutment in the back so that the access comes on the pink part of the bridge. You just need to rotate the 30-degree abutment. And then you rotate and the final bridge comes correct. On the lower, we have even a bigger problem, because on the right side of the patient, you see that the prosthetic screw is coming on the vestibular side, on the buccal side, and that cannot be. So that screw, that abutment, must be rotated to be either on the occlusal surface or on the pink part of the bridge. So once you finish the surgery and you place the temporary bridge, this is the time that we can correct the mistakes done. And it's very difficult to place the implants in the right position in the first day. Normally, the abutments. Normally, we always have to touch the abutments after placing the temporary bridge because of this reason. And of course, once everything is done, we have a beautiful smile because we control the size, the shape, and the color of the tooth. We control the size, the shape, and the color of the gingiva. The most beautiful bridge, these bridges, as I said yesterday, were developed by us in 1998. We developed the CAD-CAM bar, and then we started to place the ceramic teeth or the acrylic teeth on the CAD-CAM bar. And this is, we call these bridges the Malo bridges. As you know, yesterday I already mentioned that. We have the Malo all acrylic bridge. The Malo all acrylic bridge, there's no metal, it's only acrylic. And that can be also, it's always a temporary bridge. It's the bridge that we do the first day, but can be also a final bridge. Because if the patient has lost a lot of bone, then the Malo all acrylic bridge